Hello and good afternoon to everyone. Thank you very much for joining me. I'm Dr. Philip McMillan, and I'm here to be focused on a review of COVID-19, looking at our conferences since July of 2021. So we've had about five big conferences, and it's been a tremendous honor to have all these people from across the world sharing their ideas. And I apologize to my LinkedIn audience. Sadly, I am in the bad books at the moment, and so I am not currently on LinkedIn. Hopefully, that will change in the near future. However, if it's not, you can always find me here on YouTube or on Substack. And so, similarly, we have a lot of voices that need to be heard. We're coming to a very challenging time of the pandemic. It is certainly not over, and we need as many ideas and solutions. And so, this today has given me a chance to discuss with some of our wonderful guests about some of the thoughts that they have had over this past year, beyond and through the conferences that we've had. So I'll add my guests in quickly here in a moment, and I'll get everybody to quickly introduce themselves. We're still waiting on a few people to join with us, and that's something that we'll get them to introduce themselves subsequently. So can we probably start with just a quick introduction? I'll start with you since you're the top, Professor Banerjee. You want to do a quick introduction?
Good evening, everyone. I am Amitav Banerjee. By training, I am an epidemiologist. I served in the armed forces as an epidemiologist for over 2 decades. And presently, I am in a teaching school. I am professor and head of community medicine. And we have been following this pandemic for the past 3 years. And we are given the responsibility of monitoring the pandemic population of 30 lakhs. So, briefly, when I talk of epidemiology, I'll be touching upon it. Thank you.
Wonderful, thank you. And Dr. Robinson, Tim, how are you? Can you?
Hi. Hello, everyone. I'm Tim Robinson. I'm a retired general practitioner. Now I've been working in the long COVID services in the southwest of England for the last year and a half now. I run two long COVID services, so patient interface, managing their care, but also I oversee another 8 services within the southwest for the National Health Service England. Thank you.
Wonderful, thank you. And Jennifer?
Aloha, everyone. Good morning, good afternoon. Thanks so much for having me back, Philip. I have a PhD in microbiology and molecular cell sciences with subject matter expertise in respiratory viruses. I spent my career working in studying the pathology and immunology of mostly influenza viruses. I've managed government contracts for testing candidate vaccines for Ebola viruses. I've also most recently worked as an epidemiologist at the Hawaii Department of Health, was on the front lines of the outbreak response, doing over 700 case investigations along with contact tracing. So I have a unique mix of experience from both the research side as well as the public health side.
Excellent, thank you. And Carlette, yourself? You have to unmute your mic, Carlette. I think you're still muted, Carlette.
Oh,
Yes, go ahead. Yes, you're unmuted now.
okay. All right. Thank you, Phil. Dr. Carlette Norwood-Williams. I have 35 years in pharmacy practice, clinical pharmacy, and pharmacy administration currently. My background is inclusive of geriatrics and infectious disease, and for the novel treatment for the coronavirus, defense of the body versus virus eradication.
All right, Carlette, I think that we got some of that, and we're going to have to work on your, just in case, your internet connection. Yes, it seems as though it's breaking up a little bit, Carlette. If you're struggling with that, what I'd advise you to do is switch off your video, and let's see whether or not we get better sound quality. Yeah?
Sure.
Yeah. Okay. Great. All right. So yes. So I think that probably when we were thinking, the conferences went first, long COVID, then it went to upper airway, then it went to treatment, then epidemiology, and then vaccine solutions. I think, however, it may be wise to start with the epidemiology. And so it would be useful to hear from you, Amitav, as to what are your thoughts currently as to what we're seeing with regards to COVID-19 across the world?
Thank you, Philip. I will start with my area where we were directly monitoring the epidemiology. As I said, we are school is medical school is located in a township, Pimpri Chinchwad. It's a very big industrial township of about 30 lakh people, and highly congested parts also. So we have got industrial belts, and and we have got affluent part also. So it was a good crucible to study the epidemiology after the first wave, which was quite fairly intense in our country. We did a zero survey. We were given a task to do the zero survey. We found over 35% of the people in the township of 30 lakh were having the antibodies, but it was not homogeneously distributed, the zero positivity. The slum area and the tenements, where they are very crowded living conditions, they had almost 70 to 80% in some pockets, zero positivity. Whereas the more affluent housing societies, they zero positive was 5%, 10%, or not more than 20%. So there was a two type of population. In India is very diverse. We have the richest people, we have the poorest people. So the poor people got a sort of a natural immunity before the vaccine was rolled out. I would say about 30% of the population, or 40%, and the upper and middle class were protected. And subsequently, when we identified the people with antibodies, we followed a cohort of about 1,300 people right up to the second wave and beyond. And we found that those who had antibodies in the first wave, only 10 or 13 out of 1,000 plus uh, had a second infection during the second wave, Delta wave, which was more severe, in fact. But less than 1% had a reinfection or a second infection, and all of them had very mild infection. So we had published it in preprint also. That means that having encountered in a dense population, they had immunity which could tide them over the second wave. So what happened after the first wave was over, somewhere in 2021, January, February, all the cases in India came down, and it gave a false sense of complacency that the pandemic is over, and everybody came out. The upper and affluent classes, those who were protecting themselves by working from home and COVID appropriate behavior, they also came out, and then vaccine started. But before the coverage could roll out properly, there was a very vicious second wave, and then large number of people, the middle class and upper middle class, those who were more westernized and slightly obese and different lifestyle, and they were protecting themselves during the first wave, they wore the brunt of the second wave. And there was a chaos, medical stampede, because the hospital beds were not available, and it was a panic. And then subsequently the second wave also came down. So what was my hypothesis is that everybody will get infected. You cannot prevent it, you can postpone it. And subsequently in India also, in the national level, there are certain states which did very well in the first wave. That was Kerala was one example that was taken as a model, because they could maintain the population isolation and other things, but subsequently they lagged behind. And if you see the global landscape also, those countries like Taiwan, Australia, New Zealand, they did very well in the initial part. Now they are having a lot of problems, even in spite of large vaccination coverage, high vaccination coverage, almost 80% vaccination coverage. The Taiwan is having a high number of cases and deaths also. Similarly, Australia compared to the previous performance. Similarly, Israel, Singapore, Malaysia, and Indonesia, lot many countries. So ultimately, what happens is and then subsequently studies from Israel also has brought out that the naturally acquired immunity is 13 to 27 times more robust than the vaccine immunity. And the new variants are escaping the vaccine. Probably they are not escaping so much the people who have acquired the natural immunity. This is one aspect of the epidemiology. Other aspect I had presented earlier, there was a difference in the different continents. The Western countries where the obesity levels were very high. The BMI levels were 3 times higher BMI than the Asian and African countries. So high BMI correlated, the obesity correlated with high mortality and severe COVID deaths per million. In fact, 10 times more deaths per million the Caucasians, the European countries and the American continent were having. Asians were having 10 times less, Africans were having 20 times less mortality. Japan is a very good example, which has a very high age, but it has a very low BMI, average BMI of people, almost like a. So it was having a very, that is also very interesting. It was having a very high, less mortality, but after the vaccine rollout in Japan, Japan also showed a spike. So it requires a proper follow-up to what is happening, that why, as expected, the vaccination coverage is not really curbing as it was expected. And there have been studies also that 68 countries and 2947 American counties, they did not find any correlation with the vaccine rollout and the trends in COVID. So it's a very, we require skills which we are not. One important thing we lost is that going for, particularly in countries like India, where we had almost 70% natural immunity before the vaccine rollout, we did not keep a control group. We went for mass vaccination. So we don't know whether the long COVID, we have got a good people who have large number of people who had acquired the natural infection and recovered. So this would have formed a very uncontaminated group for studying long COVID epidemiologically. And now we are vaccinating them also. So we do not know any adverse effect long term, whether they are due to vaccine or due to long COVID. So we are losing the opportunity by mass vaccination. At least we should keep some group who have been recovered, and we can take a chance, because we know that those who have recovered have got 13 to 27 times more robust immunity than the people who are vaccinated. So there is no ethical problem of depriving them of the vaccine. So we could do, if you want to establish what is long COVID. Thank you.
Yeah, wonderful. That was quite a comprehensive overview. It would be interesting to hear your perspective, Jennifer, from the Hawaiian, because you've got some epidemiology input at your side. Any thoughts on what Amitav has said?
Well, I was involved in 2020, so I'm not certain about secondary and third waves here in Hawaii. So from my perspective, again, yes, obesity seemed to be a very big risk factor, and along with that, diabetes and hypertension. So it's all one package. Usually, people who are obese tend to have diabetes and other issues. So most of the people who were hospitalized that I saw who were having severe disease were also similarly have similar underlying conditions. So here in Hawaii, we have one of the highest vaccinated populations. Over 70 or 75% of the population was fully vaccinated after receiving the vaccines. Here, what I can say is we started to see the highest case rate of the during the entire pandemic. So it's an interesting correlation. I have seen the data that's coming out now. We have this Walgreens data that's been really good as far as tracking cases that are people who are being tested through Walgreens and according to their vaccination status. And it's quite interesting to see that there seems to be a dose response with these vaccines. So more with each successive injection, we're seeing higher cases. So that's an interesting correlation. It should actually be the inverse, one would hope. So yeah, I have more limited information than Amitav, but similar observations.
Yeah, thank you very much. And I mean, Tim, at the moment, I think the UK is leading the world with regards to the growth of infections, and that's very worrying. I mean, not necessarily from an epidemiological point of view, and we're going to come on to long COVID shortly. But any thoughts about what you've heard?
Um, I think comments really revolve around reporting, um, and the concerns are that obviously testing with the dropping of testing, therefore the numbers, where we are wondering whether the numbers are actually realistic, and I think that sort of extends across and around the world. Yes, we are only as good as our data, and so what can we go on if we're not testing and we don't have reliable data? That is a concern I have, and yes, of course, the numbers in the UK are skyrocketing, and there is great concern, and I don't feel that we've got a hold on the actual reality of the numbers.
Yeah, I think that's quite true. And from Carlette, I mean, I know you're not necessarily epidemiology, but anytime we touch on a topic, if you have any thoughts about it, it would be useful to hear. Any thoughts about what you're seeing or hearing on the ground in the US?
Yes, yes,
Hmm.
yes, absolutely. I love the speakers who are assembled here, and so I'm taking notes. Dr. Banerjee said, the first wave was very intense. By the time the vaccinations rolled out in India, they did have some mass natural immunity, and then they moved the vaccine population in Hawaii 75% adoption, and then the high you had COVID after those vaccination rates. Then you have the
Carlette, I'm sorry to say, but your audio is breaking up at the moment. So we're only partly hearing what you're saying.
some of the cases are skyrocketing. That's what
Carlette,
I'm
can you hear
affiliated with
me?
is not as many.
Okay, Carlette, I think we've lost the connection temporarily with regards to Carlette, and so
And
yeah, so I don't think Carlette
a
can
lot
hear
of
me
so
either.
pharmacist perspective, knowing that the
I guess she
Yeah.
needs to go around a apartment or a house
Yeah,
and turn off all the
I think
devices.
yes, our thing is slightly off in terms of the connection at the moment. I think we'll get her back in a minute, and let's hope we get a better connection. But yes, so it emphasizes the point that from an epidemiological point of view, we are in a phase of COVID that I don't think we could have expected. And I think that's a reasonable perspective to say at the moment. I don't think we could have thought we would be where we are now. And it makes it very concerning as to what happens next. Are you back, Carlette? Can we hear you?
yes, can you hear me now?
I just a bit, and again, it seems as though you're still breaking up a bit. So I wonder whether or not the video
Let me
may
turn
be
off the
taking up
camera.
too much bandwidth.
What about now?
Yeah, hearing you now.
Is that better? Okay,
Yeah, I'm
great.
hearing you now.
So in
Yeah.
brief, because okay, great. The coronavirus as a species mutates much more rapidly than other similar viruses, if you would call flu virus or what have you. All of them mutate. But with it quickly, are we simply chasing our tail with promoting boosters. I'm not trying to promote being anti-vaccine. I'm not either way. I'm not trying to take a formal position there. But I learned a propagation of all of these boosters, the contribution of boosters to the development of the mutations. Note, the booster they're giving you has not been modified to address modifications in the or mutations in the strain. They're giving you the same booster.
Mm-hmm.
Now, the
Yeah,
recommendation from the FDA has been that as we prepare boosters to go into the fall, modify the booster. But there's no modification. They're giving you the same thing.
and it raises an important point that again I'll highlight. I think it's a controversial point that when we had John Abeles on, he had made this point about it almost makes us question what is the mechanism that we saw protection for about 3 to 4 months with the vaccine, first dose, second dose, booster dose, fourth dose, because when I looked at the autopsy results, and we saw that some patients with still viral dissemination had antibody levels greater than 2,500 international units, it makes you realize that could it be that the mechanism of protection, because there's clear benefit with the vaccine, but it doesn't last too long, is it that that mechanism is more to do, more like with a monoclonal antibody infusion, where it has a general immune suppressive effect that reduces the risk of severe hyperinflammatory response, which has been characterized by severe COVID-19. And it's a question kind of that I put there. I'm not sure if anybody wants to make any comments about it before we shift along.
I would.
Yeah.
And that is, okay, yes, it felt like the vaccine was turning the ship around, and the numbers were dropping. But what are we seeing now? The numbers are racing up again. But that has come at the same time as we're dropping our shields and dropping our distance. And so why is it that the vaccines don't seem to be as effective? Is it because they're not as effective, or is it because we've stopped the measures? And so we were patting ourselves on the back, thinking vaccination, look at the numbers drop. Is that because we were being social isolating, etc.? I don't know. I'm not an epidemiologist or a virologist.
So I can comment too. So we know that these vaccinations don't produce sterilizing immunity, so they're skewing the immune response to the one specific viral protein. We're not getting broad and robust immunity from these injections, as we see with actively acquired immunity after being infected and recovering. So again, as I've said before, we don't know the correlates of protection. Is it antibody? It doesn't seem to be antibody. We have to look more at memory T cells that are being promoted from these injections and how broadly protective those are. And then with the shift of the variants, again, they're escaping that whatever immunity that is being induced by these vaccines. However, with each successive injection, we're seeing a shorter and shorter lasting protection. So with the most recent boosters, protection starts to wane even sooner, within weeks instead of months. And then again, as Carlette mentioned, we're still using these spike protein from the original Wuhan strain instead of updating this to be the more updated variant. So that's a huge issue in terms of matching. And we see this with flu season also, matching the vaccine to the circulating strains. So I thought that the reason they chose this mRNA technology for the vaccine was so that they could readily update these to match currently circulating strains. The problem is, because it's such a highly mutable virus, we're basically chasing after a moving car. So like, we're not going to catch this virus with these vaccines. It's going to be, nature's going to be faster and smarter. And so we're going to almost have to predict what the next one is to be able to make it's akin to like the flu vaccine, predicting what the potential circulating strains are going to be, and then make a vaccine, and hopefully we match that or catch what that next variant or mutation is going to be.
So it leads me into probably one of the very first conferences we did with regards to long COVID. And it would be really interesting to hear Tim's perspective on where we are in terms of the UK with long COVID. But the more that the virus spreads, are we increasing exponentially the risk of getting long COVID? And this is another very important question that we do have to get a handle on and an answer for. And so if you don't mind just giving us an idea, Tim, as to where things are with regards to long COVID.
Yeah. Okay, well, just to answer that last, the last comment you made, you know, the COVID symptom study, the Zoe app, has demonstrated that Omicron BA1, note I'm saying BA1, not 4 and 5, BA1 versus Delta, 50% less chance of developing long COVID from Omicron BA1. So that is encouraging, because, you know, when we cut to talking about long COVID, that is my main concern. The rest is what you guys are thinking about. But as far as long COVID is concerned, it's been a very fascinating journey, in that, you know, initially it was, as we all know, thought as a respiratory disease, and so it was taken on by the respiratory physicians and the pulmonary rehab physiotherapists. But then because of the common occurrence, the 80% of patients having fatigue, then the chronic fatigue services were brought into the long COVID team. But even that, it seemed that wasn't enough, and so other teams were brought in: the psychologists, the speech and language therapists, the various other teams, to make a multidisciplinary approach. And so I think that's what we've discovered, that actually it is because it's so polysymptomatic and multi-causal and multi sort of pathology, we need a true multidisciplinary approach. And that's been exciting to see that working. And I think that's really the 89 clinics that are around the UK are demonstrating that quite nicely, that each patient is treated on an individual basis, and they are offered a whole raft of therapies, plus some pharmacological intervention for anti-inflammatory, such as the use of colchicine now, which is previously just used for gout, the use of the selective sinus nodes receptor blockers, so ivabradine for the dysautonomic patients. So there's been new treatments brought in. But I think our problem, so in other words, I think it's all very exciting, and there have been massive developments, and it's all working much better for our long COVID patients. However, long COVID itself has had a bit of a stormy journey with regard to acceptance by not only the general public, but also the medical fraternity. And also, perhaps, I'm just a bit suspicious that from a sort of politico-economic point of view, I think that they see it as a massive time bomb about to go off with regard to being able to pay for, you know, these patients who again, knowing that the prevalence is female and working age group, a lot of patients are not being able to work, and their sort of vocational and occupational side is completely jeopardized by having long COVID. And so obviously people are beginning to think, okay, what about compensation, or who's going to pay for this long-term condition, long-term sick? So I think that there are many strands that complicate the whole the whole long COVID picture on many strands, many levels. So not only in the conventional medical side, then there's this sort of there's the political and economic side.
Yeah, that's very valuable. And one of the interesting questions that I wanted to ask Amitav is, I remember asking a doctor in the Philippines about long COVID, and it was so interesting that his response was, yes, we know about it, but we don't really see it. And it was a similar response in Pakistan as well. And I thought to myself, isn't that strange? What is the experience in India with regards to long COVID? Have you seen anything, Amitav?
In fact, this is compared to the population we had and compared to the infection spread we had. As I said, as on 80% of our population had already encountered the virus. Compared to this large pool of infections, we don't see so many cases of long COVID. In fact, we had taken up a project which was not, in fact, approved also. I think it's a very complicated thing, autoimmune or hygiene hypothesis. I think there may be racial differences. Perhaps people staying in highly dense countries like India and other African, Asian countries, their immune system perhaps reacts differently compared to those who are brought up in more less dense countries. So perhaps there's a thinking on those lines. I think Philip may be doing better, being an immunologist, about the hygiene hypothesis that people who are. So we have been exposed to so many coronaviruses and other things. So case definition is very difficult. As I said, we don't know, because we have a large cohort of people who have encountered the infection, but we don't see so many cases. And defining long COVID can also be quite messy, because as Tim also said, the Delta variant, we had seen more cases of long COVID compared to the Omicron. But when in the initial stages, Alpha and the initial stages, there was a lot of mismanagement of cases, say ventilators and other things. They might have caused some lung trauma. We don't know, remdesivir or something. And subsequently, we were more trained in treating patients in a more rational manner. So those are so many factors, very difficult to tease out how to define a case of long COVID. Then the psychosomatic element also comes, compensation comes. So we don't know exactly. So we should have a very good control group. And I think our personal experience is not much we see in our country. Yes, Tim.
Yeah, go ahead, Tim. What do you think?
Amitav. Okay, remember that old adage: if you don't look, you don't find.
I agree.
So is it a case of because it is poorly understood, and as you say, the definition is a bit messy? You know, yeah. There's WHO's version, there's the NHS version, there's the American version. Is it because the actual diagnosis, the definition is messy? And is it because we're not tuned into it? I mean, is it, or not we? I mean, countries that are saying that haven't got long COVID haven't got any long COVID. They're not seeing any. And actually, guys, when we look at the pathophysiology of this disease, does that mean that all those other countries, other than England, have had a much gentler COVID illness, COVID experience? Because hold on, what do we know? The pathophysiology, the multiple immune inflammatory dysfunction must have led to all the other things that we are seeing in the UK, such as dysautonomia and all the microthrombi and the mast cell activation. So that must be happening throughout the world, because it's the same virus, different variants, but same virus, wild type and alpha beta. So there must be long COVID, and I feel that it's just being underdiagnosed because they're not looking for it. I mean, Northern Ireland have only just got their first sort of, and a lot of people behind the curve because Northern Ireland have only just got their first clinic. Wales have now only got 2. We in the UK, in England, we've got 89. Biden has just recently said that there will be a long COVID clinic in every state, but that's small numbers. So I'm wondering, if we don't look, we don't find.
Interesting. Carlette, any thoughts on what was being said there? Because you can see from the US perspective.
Absolutely. It was just remarkable listening to Tim's summary of the impact of long COVID, and he's exactly right. Providers are challenged with classifying long COVID appropriately. ID9 and CPT codes. And so if there's no code or coding to bill for diagnosing and treating long COVID, it doesn't exist. What you have is what they're calling some vasculitis and you have for development of diabetes. You have disease state to treat, and no one is making a composite of these multiple disease states that were non-existent now culminating in a system dysfunction that is long COVID. How do we clearly define and standardize the diagnosis of the long COVID condition? Now, people who have these multi-system challenges post-infection, they now have multiple specialists managing them. They have a pulmonologist, endocrinologist who are dealing with these new applications. But I received a surprising communication through LinkedIn from a gentleman out of San Francisco who at Cambridge some doctoral fellowship in neuroscience or some such post-COVID complications. And he said, I think we missed something. ICAM can treat post-COVID complications. I said, well, I'm not familiar with ICAM and long haul. I know nothing about this. He says, well, there's a support group out of the UK and Australia that are the long hauler support group. And it appeared that 2 weeks of the regimen minus the macrolide, but with immune support, high dose immune support, the corticosteroid, dealing with the inflammatory challenges that have been lasting for them, a 2-week regimen seemed to make a major difference. They wait a month and they do another 10-day course, and there seemed to be some type of correlation with a reactivation of their immune system and reducing some of the inflammatory challenges. So that anecdotal, of course, is something I wasn't looking for, but this physician happened to be a physician whose daughter is in the UK, and her colleagues, were COVID positive. They weren't admitted apparently because of their age concerns that they weren't at risk for death. Have been dealing with some post-COVID complications for 8 months, and felt this particular immune support anti-inflammatory regimen seemed to pull them out of the of dealing with the after effects of a severe COVID situation. So I use that concept with a family member of mine, post-COVID complications. Sure enough, it seems to really make a major difference. So they're doing, instead of the standard 5-day course, they do a 10-day course, and did 30 days and did another 10-day course, and it a very big difference in their mobility, their breathing, and some other issues. But of course, that's anecdotal. But until we can get a clear, definitive population study that says these 3 out of 5 conditions are reflective of long COVID, maybe it's starting as an overview of the literature, but there has to be some between when you have these types of disease states, new developments in a single person post-COVID, then that's a long hauler.
Yeah, thank you. Thanks a lot with that, Carlette. And Jennifer, I don't know if it's something you come across in Hawaii with regards to the long COVID. Just quickly, I'm going to make a comment, but I just wanted to hear what you thought, Jennifer.
So I'm not a clinician, so I'm not seeing patients, and past them being discharged from the hospital, I don't know what happens to them. So from my research, long COVID is chronic fatigue syndrome. So we see this with other viral infections as well. And it usually has to do with hyperactive immune response. So it goes along with a lot of what you've said, Philip, in terms of what COVID is, in terms of autoimmunity and immune dysregulation. So those who have severe disease have more immune dysregulation and inflammation. So this is followed by immune exhaustion. So what Carlette is saying, I think, is very pertinent, because if you treat the immune dysfunction and give immune system support, I think that can help rebalance the immune response and get people back. We've known about chronic fatigue syndrome. I think it was first defined in the late 80s. So, chronic fatigue, brain fog, all of that. It's not new. Again, we see it with a lot of other viral infections as well.
There's an interesting thing that I wanted to say, certainly with regards to what Amitav said and what Tim has said. I do think it is possible that they're not underdiagnosing in some of the other countries, because it's difficult to underdiagnose a disease that really knocks people off their feet where they cannot work. So it's hard for people to just get on with it, even in a culture where it's not acceptable. So here is what I have noticed. I have noticed that the people who seem to be most at risk of long COVID have associated gut dysbiosis prior to having COVID-19. And when you look at gut dysbiosis or gut-related immune problems, they predate the COVID-19 and tend to be far more common in Western societies with Western-type diets. And so I wonder whether or not what we're seeing here, because at some stage, it has to be either they are completely, and I'm saying this is not a slight difference, this is a humongous difference with regards to the numbers that they're seeing in India, in Pakistan, in the Philippines, even in Africa. And then you compare it to what is happening in Western societies. I really am beginning to feel strongly that this is very closely tied to diet and underlying gut disease as a primary driver for the immune mechanisms that we're seeing with long COVID. And because the Indians have so much curry with the curcumin in it, they probably are at low risk. I don't know, but we need to figure it out.
Many factors are there. The immune exposure since childhood to different coronaviruses, and it requires a lot of basic research, epidemiological research, clinical research. All have to come together on board. As Philip said, this is the time when we have to collaborate rather than work in compartments.
Yes. So that brings us on to a question, and I'd probably like to start off with Carlette. Carlette, I hope your signal is good. If I take you off, it means that we're losing your signal temporarily. But I wanted to ask you with regards to your unique thoughts with regards to what happened from a treatment point of view. You were at a unique place in the pandemic, and when we had innovative ideas for treatment, they seem to largely have been lost. What are your thoughts on where we were and where we are? You're muted at the moment, Carlette. Carlette, can you hear us? You're muted at the moment. Can somebody just type a quick message to let her know that we're muted. It's a pity that we don't have Dr. Fernando Valerio. Go ahead, Carlette. You're
Okay,
unmuted now. Yeah.
you hear me now?
We're hearing you. I just want to hear whether or not there's any issue with your
Okay,
microphone. Just keep talking. If there's a problem,
you
I'll
were
interrupt you.
okay. Great. So when I wanted to prepare for the discussion today, my focus was really to look at the evolution of COVID-19 therapeutics from the 2019. We're all familiar with the celebratory response that we heard when it was determined that hydroxychloroquine and azithromycin showed some positive outcomes in a small group, maybe 38, 36 patients or so, and maybe 12 did well. And so from the pharmacy's perspective, we were concerned not just about hydroxychloroquine, but the doses that would be required, and in patients with QT prolongation. But it was asked for. We would order it, but subsequent to global demand, hydroxychloroquine was no longer available. And then the attention was moved toward ivermectin, and ivermectin was shown to have positive outcomes. But from the pharmacy perspective, we know that once you get past drug indication, we are concerned about dose-dependent effect, right? So even if it was intended to work, the doses required in ivermectin to treat COVID was a concern for risk of harm to the patient, and it's a careful balance. But now, they were looking at remdesivir. Remdesivir had showed promise and benefit in Ebola, and so even though it was indicated as an HIV drug, there was a concern that we need to be able to access remdesivir. Not enough to go around, so there was criteria for use that was implemented that limited its availability. When the ICAM protocol was developed, it was simply because we were on a waiting list for remdesivir. We weren't sure we were going to be able to get it, and we wanted to use what we had on the shelf versus nothing at all. Had very positive outcomes there. Unable to release that to the masses as a formal IRB published study, so transition to convalescent plasma and dexamethasone, and those became the standards of care globally, remdesivir and dexamethasone. But there was still only about a 30% survival that was documented using those interventions. Convalescent plasma was a promise that really didn't live up to the initial claims as well. So now we have transitioned to the vaccines as a priority preventative. Does absolutely show some definitive benefit of less hospitalizations, even if there are some collateral infections seen despite the vaccinations. But the novel monoclonal antibody infusions, particularly for those patients who declined vaccination and decided they would wait for those, resistance developed with that therapeutic intervention as well. So now we have approval to use remdesivir much earlier in the course of viral infection, as well as Paxlovid, the oral antiviral intervention. And then in April, it was released that using Paxlovid, a certain percentage of patients, a low percentage, it has been said, would develop rebound coronavirus infection. And the issue now is not that someone gets coronavirus infection. The perspective overall is that they are not as lethal and not as severe, won't require hospitalization. However, if you're experiencing a rebound of COVID symptoms, if it's able to detect, it's able to infect. So now you are spreading COVID even more so because you thought you were better, only to find out that now you're still positive and you're able to further infect those. And those individuals who have some compromised immune systems are going to always be at greater risk of healthier individuals. So as a pharmacist, I am at a polite conundrum. I am throwing my hands in the air because in any other clinical setting, if there is evidence of resistance or poor and infective sensitivity to the therapeutic that is intended for treatment, we don't recommend using that. The minute it is determined through the minimal inhibitory concentration, or the MIC, on the culture and sensitivity report, that sensitivity is not potent and that there's a risk for resistance, we don't recommend that agent. But yet Paxlovid is still being recommended because the opinion is that even if you get a rebound COVID infection, it won't be severe, you won't go into the hospital, but you're still infectious. So, that's just where we are today. I hope I gave a good overview.
That was
from
a very comprehensive
now.
review, Carlette. Anybody want to step into that question about treatment options?
Hi, Carlette. So Carlette, what about sort of anti-inflammatories in the UK long COVID arena? We're using colchicine a lot for the pleuritis, the chest grip, the lung burn that patients are experiencing. So that's quite a novel, if you like. It's off label, as well as repurposing a drug, because as you know, it's used for acute gout. But I think that's fascinating.
Mm-hmm. Yeah, and Amitav, I wanted to
I
ask
agree with you.
So, go ahead, Carlette.
I'm speaking more comfortable with colchicine. I am actually more comfortable with the anti-inflammatory benefits of colchicine because it still doesn't seem that the dosages are the same level of risk of high dose hydroxychloroquine and higher dose ivermectin. I believe that we should have always approached coronavirus due to its inflammatory pathogenesis. I believe that we should always start with an anti-inflammatory intervention to interrupt the course of the severity of the disease. Viruses only live 5 days for the most part. Other than HIV, the coronavirus lives 5 days. The flu lives 5 days. No one dies specifically from coronavirus. They die from the complications of uninterrupted inflammatory progression in the pathogenesis of the virus in the body. So you deal with the inflammation. But I also believe you must deal with the challenged, compromised immune system. I believe that they are married. The inflammation would not be able to get a foothold or an anchor if the immune system was strong enough to prevent it or combat it or be in defense of the body. So I agree. Inflammatory approach should be our priority, but it should be married, in my humble opinion, with an immune stimulatory impact.
Go ahead, Tim.
Whilst I'm still with Carlette, can I just ask one other question? So Carlette, what about DOAC and DAPT? Thinking hypercoagulable state of COVID, acute COVID, resulting in microthrombi, which obviously the Pretorius et al. In South Africa have identified the amyloid microthrombi. So what is the position in the US with regard to treating patients with dual activity, dual action antiplatelet, as in aspirin and clopidogrel, along with a DOAC? The one which most people are prescribing is apixaban. What's the view in the US with regard to that whole hypercoagulable state and treatment of?
The health systems that I hear are not ordering preventative anticoagulation upon COVID diagnosis. I do. I believe that the standard inflammation, we deal with the immune challenges, and we add anticoagulant as a preventative due to the progression of the inflammatory pathogenesis of COVID. Now, here in the U.S., what I am familiar with, I'm not a practitioner. I'm a pharmacist, second line. What I'm familiar with is onboarding of an anticoagulant with post-COVID complications. Familiar with bringing on an anticoagulant hospitalization as they are progressing in their requirements of clinical care during the protocol that we had worked with before started with immune support, corticosteroid, and anticoagulant as standard. And I think it simply makes sense because the hypercoagulable state is part of the pathogenesis of rampant inflammation in the COVID infection. It just makes sense to me. But I haven't heard that it is currently standard of care. I've sort of been limited with any further research, and that's another situation.
Excellent.
But it
Yeah.
should be the approach. Now, you mentioned DOAC. DOAC, apixaban. I'm sorry.
No, go ahead, Carlette. I thought you were
Someone
winding
say
down.
something.
Make the point about
I believe the
apixaban.
DOAC, apixaban. Yes, the DOAC or the apixaban has been the singular use that I have. If I have a patient who comes or a physician who comes with recommendation, and it's, apixaban is in the U.S. very expensive. Uninsured prescription is high, $300 here. It's not generic. So when people do not have funding for the apixaban, then I've always recommended high dose aspirin versus 1 milligram. We have a 325 milligram here, once or twice a day, based upon the patient's risk of coagulability. That's all.
Excellent. Yeah, wonderful. I wanted to ask Amitav a question because one of the interesting things about treatment early in the pandemic was this situation with is it Uttar Pradesh, where they used a treatment protocol combining vitamin D, I think ivermectin, and a few other things. They gave it to the population and they absolutely crushed the death rate in that region. Now, they have pulled back on that remarkably, even after the success of it, which I found even strange. And actually, here's an interesting fact. At the time when Uttar Pradesh was in its worst phase, they were only 20% vaccinated. They did this,
Yeah.
they completely brought down the numbers. Then they stopped it, and now they are almost 90% vaccinated, and the numbers are going up again. What is this? So any thoughts, Amitav, from a treatment perspective as to how India approached it, certainly with the Delta wave differently?
You are right. Uttar Pradesh, they started giving ivermectin, and in fact, they went house to house and gave ivermectin. It was a part of a package. And of course, the cases came down, and there were some few studies where they found that ivermectin even was used freely in India. There was no ban. That is one thing, like most countries, they had banned ivermectin. But India, it is freely available because it is used for worm infestations and other things. So it is over the counter, it is available. So definitely, this is a drug which has not been really, really got its due perhaps or studied well. And actually, as I said, throughout the pandemic, things have been very messy because nothing has been kept neat and clean. Even now, we are going for those who have recovered also, we are giving vaccine. So we wouldn't know what is working, what is not working. And particularly in a healthy person, the output is so less that it is very difficult statistically to establish any intervention clearly. I mean, whether a drug is working or whether a vaccine is working, particularly among healthy populations. And particularly, so it's become very messy. I mean, now a number of boosters you are giving. I mean, I don't know. I'm not a clinician, neither I am a basic scientist. I just count numbers. But I sometimes question myself whether this number of boosters can also cause some immune modulation or something. I wouldn't know. And already a person already has got antibodies or antigen exposure to natural infection, particularly in densely crowded countries. So until unless we keep clean groups, clean cohorts, uncontaminated cohorts, that those who have just recovered from natural infection, follow them forward for long COVID. Those who have got vaccinated, follow them forward and compare them. We would be very difficult to establish, and particularly pulmonary diseases like COVID. You are exposed to air pollution, you are exposed to other infections. Interim, in between, over a period of time, you may be exposed to other pathogens. So we don't know what is causing, whether it is clear attributable to COVID or reinfection, like we have got tuberculosis in our country. hidden tuberculosis. So we don't know what is, I mean, it's very difficult. I mean, if you look for something, you will find it, but that can give prejudice also. I mean, with all regards to Tim. So sometimes the knowing something gives you prejudice, particularly in epidemiology. Clinician, that term is used for clinicians. The eye does not look what the mind does not know. But an epidemiologist has to be totally blind. So our approach is different. So that's
Yeah,
why
so
we have to come together and come to a negotiation and some give and take and some trade-offs. Then only we'll get the full jigsaw puzzle or whatever puzzle we can solve it.
absolutely. I just wanted to get Jennifer's thoughts with regards to, from a treatment perspective, what we're seeing with regards to antivirals and the thinking from a virologist as to why we're not, say, getting more success with them.
Certainly. So, viruses are tricky. As Carlette said, we have to worry about resistance. So antiviral resistance can be a real problem too. So, again, I go back to flu because that's my main expertise. And we see this with influenza, the amantadine and romantadines cannot be used because flu viruses became widely resistant. So we have to be really judicious in the use of antivirals to avoid resistance. So that being said, I think early treatment is really key to decreasing the severe effects of the disease and also in reducing spread and transmission. So early treatments and determining what that should be very key right now because of the failure of the vaccine program. So making sure that we get people early and get them treated so that they don't progress to severe disease and have to be hospitalized. I think that should really be at the forefront right now. And we also need to look at, I think I've said this before, pivoting and looking at treatments like Dr. Robinson is doing for long COVID, but also for those who have been vaccinated. So we need to look at treatment and support for those people and the coming possible effects of all these booster doses that people are getting.
Yeah, yeah. So we're in a complicated phase, and I think that one of the things that I'd recently shared about is that I think that, as I've always said, the research pointed to the fact that severe COVID, long COVID, is an autoimmune disease. If it's an autoimmune disease where we're primarily using steroids, have we shot ourselves in the foot by priming the immune system to variants that will trigger an immune or potentially autoimmune response because they're evading the upper airway immunity? And this is really why I think I recently said I am worried that we're going to see a tsunami of disease in the next few months. And the problem is that it's not going to present as severe respiratory disease. It's going to present as almost everything else, just high numbers. And we're seeing hospitals being overwhelmed across the world. And we're not answering the question as to why this is occurring. Based on what my research is pointing to, we're likely to see a significant exacerbation, almost a very fast turnover for peripheral vascular disease and therefore thromboembolic disease, simply because the immune response can trigger plaque growth. And so you're going to see everything speeded up 2 or 3 times. And so we may not see those outcomes for another 6 months to a year, and it will be very difficult to make sense of. Already the UK is seeing excess mortality, which is not related to COVID-19. And we need to get a handle on this very quickly, because if this is an inflammatory process, we can potentially mitigate it by using drugs that reduce inflammation. But if we close our eyes to it, that's my worry. It's going to hit us like a huge wave. Any thoughts?
Can I comment? So I've said this multiple times. For over the last 2.5 years, we have been not talking about health? We know what the risk factors are for severe disease. We know it's obesity. We know diabetes, hypertension. We know what the risk factors are. Why are we not talking about health? Why are we not talking about how to mitigate those things to reducing risk primarily? And I think Carlette touched on this a little bit, immune system support. So at the end of last year, I had a back injury and I went to a doctor and actually an orthopedic surgeon. And I was very surprised because she gave me nutraceuticals. And I thought, this is fantastic. So she said, we have to support nerve support right now because they're overactive. So gave me some nutraceuticals, which is fantastic. It really made a difference. So why are we not talking about nutraceuticals? I know it seems to be a banned topic to discuss giving people vitamins and supplements and other effective nutraceuticals. We know that vitamin D is very important, has very important immunomodulatory effects. So it can help with diminishing or decreasing pro-inflammatory responses. Get outside, get some exercise, go for a walk, get vitamin D. We really need to start talking about health and support primarily to prevent. Let's talk about prevention and support first off.
Yeah, and it leads. You go ahead, Tim. Yeah, go ahead.
I echo your thoughts wholeheartedly, and it actually swings back beautifully, seamlessly to what Philip said. And that was to do with the microbiota. Okay, so the microbiota, the importance of the microbiota is that it is the immune support part of the body par excellence above all else. The 98% of the immune system is in the gut, okay, in the Peyer's patches of the lining of the gut, as well as the mesenteric lymph glands. So the majority of the immune system is in the gut. So we should be nourishing the microbiota that are maintaining a healthy immune system. With a healthy immune system optimally functioning, then it gives us a chance to not only deal with acute COVID, but also long COVID, and that is essential. We should be, and I think it's very interesting that your orthopedic surgeon, I mean, that's fascinating in itself. Orthopedic surgeons, have been sort of historically more sort of hands-on, carpenters than anything else, and that the fact that they are talking about nutraceuticals is crossing the Rubicon and actually becoming switched on and fantastic, thinking out of the box. That's fantastic. But what are we really talking about? Actually, we're talking about nourishing the microbiota to produce the healthy immune system. How do we do that? With a prebiotic diet full of FOS and GOS, as well as resistant starch, as well as fermented foods. That will, and what's more, a mixed balanced diet, a mixed balanced prebiotic diet will contain all the necessary vitamins, and the trace elements, which are essential for the building blocks of the body, but also for the antioxidants, as well as all the polyphenols that a mixed balanced diet will contain. So in a way, that's how nature intended us, and that's how we've come about. Yes, having multi-mineral, multivitamin is basically a help, but is the bioavailability as good as a mixed balanced diet? That's a big question.
Yeah,
so,
and
so can I just make one comment there?
Yes,
so
go ahead, Chantal.
Piggyback on that, we in the gut, that's where these bacteria reside that can convert our food to vitamins. So that's where vitamin D is made, is in the gut, right? So having a healthy microbiome and having those microbes that are in the gut to be able to do that is very important. And I was also going to mention fermented foods. So I don't know if people know if there's any correlation, because in Asian countries where they eat a lot of like fermented foods, and like you mentioned in India with the curry, I don't know if there's a correlation or if it's just anecdotal, but I was also thinking about fermented foods for gut health as well. So yeah, we have to think about where these compounds are derived and how they're made and how to support that naturally as well.
And so I just wanted to challenge Carlette as because she's in the pharmaceutical industry. I have found that there is no money to be made of any of these vitamin Ds and so on. Is that why, Carlette, that we don't seem to get as much traction with regards to some of these over-the-counter drugs, or I mean, nutraceuticals that don't need prescription? You're muted at the moment, Carlette, if you're responding. Yeah, go ahead.
Respectfully, Dr. Phillip, I would challenge your perception that there's no money in pharmaceuticals, because at least in the U.S., this is a multi-billion-dollar industry, and it bypasses FDA. The challenge with the adoption and the acceptance of natural medicine nutraceuticals is in the fact that there's no money in the promotion of research and development of these items. And because in the FDA, there here in the U.S., there is a standard disclaimer on any natural product. This have not been FDA approved. This product cannot be used to diagnose, treat, or prevent any disease. Once you have that disclaimer there, you can promote that and sell that product. However, you can never say that it helps you. I could never come out and say, because I couldn't release ICAM as a pharmaceutical product, I converted it to a VMH complex, vitamin mineral herbal complex. This should represent the pharmaceutical impact. Yes, in the nutraceutical realm, I could never say, by the way, if you take this once a day, it could be preventative because it boosts your immune system and helps to regulate inflammation. But if you get sick, take it. You should bypass the ED. You should be just fine. Give it to everyone in your household. I could never say that because I don't have the laboratory studies to promote that. And I really believe that the pharmaceutical industry is the major barrier into the promotion of natural medicines. But there's plenty of money, at least made here. I don't know how the UK is structured. But in the US, okay, Jennifer, you are nodding your head. You know good and well. Nature made, pharmacists recommended. So there is money to be made, at least in the States. The UK, do you give those away as just as prescription medicine, or is there a purchase industry for the UK?
Oh yes, there's a purchase industry. Yes, so certainly, I think you've hit the nail on the head, and it's the industry rather than the pharmaceutical groups pharmacists who are actually dispensing medication. You're quite right. The industry, there is not financial benefit for researching something that is over the counter and does not require a prescription. That's the truth.
Yes.
So
Yes.
I've heard
Yes.
anecdotally of
Yes.
doctors giving IV vitamin C to those in the hospital. I don't know if that's true.
Yes.
I remember having a discussion here with a infectious disease doc who's setting up treatment protocols here in Hawaii. And he said that when I asked him about, are you giving immune system support along with these other drugs, he was a little like wishy-washy about it. Well, you have to be really careful about giving these pills to people. And, certainly I have these at home in my medicine cabinet, but, I was like, what would be the risk? Like it could only help. So why not give it? If it helps, great. If it doesn't, well, it doesn't hurt. Certainly. So why not? It could be some benefit along with the
So
other
remember
treatment.
this. Remember this. Remember this concerning A, B, C. That covers prescription drug risk for interaction with natural medicine. A, anticoagulants. If you take turmeric, taking a Pixabay, what have you, dabigatran, what have you, you are going to most certainly within 3 to 5 days contribute to the development of a GI bleed. There is a significant between any anti-inflammatory, prescription or natural, and anticoagulants within 3 to 5 days in the hospital. That's where they'll go. So that's the number one. Anticoagulants and natural medicines, there needs to be an evaluation because a number of them will interact with anticoagulants. So if someone wants to access a regimen for COVID and ask me my suggestion for something over the counter, I make them aware of turmeric. It's a great anti-inflammatory, also has some immune. However, if you're and then have you talk to your doctor. Make sure you're aware of that interaction. So the first A. So B is, I got a blank. Now I got a blank. I'm sorry. B is okay. A is
we missed that. Go, say B again. Say B again.
Everyone doesn't know what anticoagulants mean. We know. But for non, you call them blood. All right. So nothing.
Oh, we missed that,
A,
Carlette.
B,
That was
C.
so
Antibiotics, blood thinners.
I see. Yeah. So the
A, B, C.
interaction.
Antibiotics, blood thinners.
And C.
Okay. So these are interactions. So for antibiotics, some of the interactions that people are concerned about is the chelation effect. Have you heard of chelation? I'd say chelation. There's another term I'm not thinking about, but some antibiotics actually will bind to some natural medicines, vitamins and minerals, and become unable. It will make a complex molecule that large. So you won't get either the mineral herb supplement or you won't the antibiotic. You'll get neither of them because they will form a complex that is unabsorbable. Not all of them, but many of them. Some key points are any of the vitamin D, not the B's, but definitely vitamin C, vitamin D, maybe vitamin A. They will bind together with fluoroquinolones, as an example, and become unabsorbable. They will pass through the gut. You wasted your money and your time. Does that make sense?
Yes,
so the
yes.
that can be formed with some antibiotics and some natural medicines. There just needs to be a review. You simply go to Google and do an interaction checker. They're all free. Just put in that antibiotic and that natural medicine and make sure that they're not one of the ones that would form the complex. So ABC. A is antibiotics. The concern is that neither of them will be absorbed.
Mm-hmm.
It could increase the effect of the blood thinner, whether it's clopidogrel or apixaban, ABC. All right.
Mm-hmm.
And the C is cyclosporin. I use cyclosporin as the object drug that transplant patients, right? So when people have a transplant of heart, lung, kidney, liver, right? Anytime they have a transplant organ, they're required to take an anti-rejection drug. The prototype is cyclosporin. They have others, but cyclosporin is generally going to always be part of that regimen. So now I'm telling you to take an herbal that has immunostimulatory effect or a vitamin, vitamin D, great immunosupport. Zinc, a mineral that is synergistic to D, great immunosupport. But if you are a person who had a liver transplant, God bless you, you found a kidney to survive, because you're going into figure. You can immunostimulate your anti-rejection drug, which acts as an immunosuppressant. So now you have potentially created a physiological environment that is rejecting the organ you were so desperate to receive. Does that make sense? ABC. Natural medicines, nutraceuticals should be evaluated. Doesn't mean you can't take them. Evaluate them.
To bring it back to COVID. To bring it back to COVID, I think what we're agreeing, Philip, is that basically microbiota is important, very important to address. And I think one of the things that you said, Philip, which really sort of took me by surprise and has really made me think and sit up, was that, okay, Philippines. You quoted Philippines. There's no long COVID in Philippines, and my response was, if you don't look, you don't find. Actually, hold on. It might be that at all. There might be no long COVID in the Philippines. Why? Because, as you say, the diet there is encouraging the microbiota. They have a really efficient immune system, and because their microbiota is so good, because their diet is different to the Western diet, they don't have dysbiosis like we do in the European countries. So you've really got me sitting up thinking, actually, this is really relevant.
Oh, yes. And I think this is where we do need the epidemiologists to break it down, in the sense that, yes, we agree that to a certain extent in some countries it may be taboo to talk about it, so people will not talk about it. However, I still think the very severe cases, you can't miss them. It's not as if they can just pretend. They will be impacted in some way. And if you're not seeing them, it's not because they are there but not found. They're just not there. And so then the question becomes, why aren't they there? What is different about this environment that increases predisposition in another environment and not in this one? And so, as I said, the gut, as far as I can see, I can guarantee you that in those countries, they don't have the same levels of inflammatory bowel disease that we have in the Western Hemisphere. And I based on the research that I'm seeing, inflammatory bowel disease is the major predictor for long COVID. If you don't have an inflamed bowel, the chances are slim. But if you have an inflamed bowel and you get COVID, there's a high probability you will go on to having long COVID. So this is what I mean in terms of understanding the primary pathophysiology with regards to the disease. I actually think long COVID is a different disease to severe COVID-19. Same virus, two different diseases. And we do see that with some viruses. I guess it's like varicella zoster, chickenpox, and zoster. They're two completely different diseases by the same virus.
Fascinating. Yeah.
So it brings us into an area that I know is your bit, Jennifer, which is to do with when we spoke about innovative vaccines. And I'm going to lead it off with a very simple question. Is it possible that an injectable vaccine cannot work long-term against COVID-19? Would that be an unreasonable thing to state?
Would you repeat the question, Phil?
Yeah, sorry. I said that, is it possible that an injectable vaccine, I specifically say the word injectable vaccine, cannot work long-term against COVID-19, SARS-CoV-2?
Well, Philip, what I've said before on this topic, when you have, there's a reason we don't vaccinate against highly mutable viruses, right? So not every virus is amenable to vaccination. And even when we talk about influenza, so I don't even call it an influenza vaccine, I call it a shot, an immune booster. So this is why we have to get it every year, because it's not something that provides sterilized immunity that will prevent infection long term. So that's why we have to get them every year. So I think this is the challenge with respiratory viruses specifically, because like there's been a big challenge when you look at creating a vaccine for RSV and other, even before SARS emerged, trying to make a vaccine against rhinoviruses and other common human coronaviruses. There are distinct challenges. So in my opinion, I think that the best we can hope for is some short-term protection from an injection against these highly mutable viruses. Like I said, nature is going to be faster and smarter in terms of mutations and escaping the whatever immunity that is induced by these injections. So we really should be pivoting to look at more preventive measures and also early treatment measures.
And any thoughts about that, Amitav?
I'll say this,
Go
Jennifer.
ahead,
As pharmacists,
go ahead, Carlette. Yeah.
As a pharmacist, we give flu shots. We give flu shots every year here in the U.S. Annual flu shot. Pneumonia every 5 years. But we do not prepare to give the successive formulations based upon the prior year's development. These are now, they were bivalent vaccines for flu originally. Then they became trivalent vaccines. Now they are quadrivalent vaccines because epidemiology and the microbiology research necessary to determine what has been the evolution for next year. And that is why we're able to more successfully combat flu. Same thing with pneumonia. All of our other vaccines, they actually go into the lab and modify the formulation of the vaccine because they've done the studies to predict or fully understand what this year's variant will look like. This is the first time I've ever heard of a vaccine with successive administrations that have had no modification of the formulation intentionally.
Yes, a very good point. Yeah.
My polite conundrum is being expressed as how it is logical and why is it intentional? These are brilliant people developing these vaccines, and maybe to be fair, we don't have any of the development. So surely we are in the midst of research and development. I am sharing that for the vaccines that the pharmacists in my charge have been administering have not appeared to represent any different formulation from the original administration of the vaccine, which was December 2020.
Yeah,
every time naked eye, I don't take a microscope, haven't seen any package insert is where we get all of our details. In a particular change, but who am I? I'm just a pharmacist.
So there are in development, I believe Pfizer has in development an Omicron
formulation of pneumonia. It changed.
Yeah, thanks, Carlette. Go ahead, Jennifer.
Pfizer has in development Omicron specific vaccine. So the question there is, now we're past Omicron into subvariants. So again, we're just not going to catch this virus.
Just to say, Jennifer, we're going to have to lose Tim at the moment. So thank you very much, Tim, for being with us. Really appreciate the input on
Tim.
COVID. Thanks a lot for that. Really appreciate your input.
Philip, thank you for inviting me. I've really enjoyed it. Very thought-provoking, as I've put in the chat. So thank you, and lovely to meet you other guys. I hope we meet again, and I hope what I've said makes some sense.
Absolutely.
Very best, and good luck to you all, guys. See you again.
Okay, great. Thanks,
Bye-bye
Tim.
now.
Bye-bye.
Bye-bye.
Yes, sorry, Jennifer. Go ahead again.
So again, Pfizer is making an Omicron-specific vaccine, but we're already past Omicron with other subvariants. So again, it's like chasing after a moving car. Like, are we going to catch this? I don't think we're ever going to catch it, and we're not going to be able to predict what nature has in store for us next. There's also talk about a universal or pan specific coronavirus vaccine that, we've had challenges with a universal flu vaccine. So something that we can give that'll cover all flu strains. And I think, again, it's going to be very challenging to develop given the breadth of hosts that we're seeing now with these coronaviruses and just the mutations that are continually, how this virus continually evolving. So there are things in the works, but again, I think there's going to be very challenging to catch up and to actually provide something that's going to provide long-lasting immunity. And I guess just trying to think about what's the rationale here is like we're looking at trying to eradicate the virus. There's only been one virus eradicated, that's smallpox, and the reason for that is because there's only the human as the host for that virus. So when you have other animals as hosts for a virus, it's very, I would say, nearly impossible to eradicate that, especially since we're seeing this in minks, just a variety of animals with the minks and the deer populations and large cats and other domestic animals. So I just think it's going to be challenging. It's going to be a long time before we see anything that's going to be effective in that arena.
What I would say before I ask Amitav his thoughts on this, but what I would say is there's a reason why I said that is the characteristics of SARS-CoV-2 is that evades interferon and it hides. And so therefore, by the time the immune system picks up on it, it's already hit the bloodstream. And so you don't get that protection. So by having the immunity in the bloodstream or systemic immunity from an injection, it can impact somewhat on severity of disease. However, that's where my other concern comes from, because if it is an immune or an autoimmune response, does it prime the immune system to overreact? And so it's that kind of trouble that I think we're going to have to try and sort out. And it may explain why, even after 11 billion doses across the world, we are still seeing an evolving pandemic. And this is why it's just a simple scientific question, because I'm looking at outcomes here and I'm looking at where we are. Any thoughts, Amitav?
Exactly, you're right. I mean, of course, vaccine and its effects, immune, I wouldn't go into much in that. But epidemiologically, strategy, the vaccine is one is the vaccine as a preventive, that is for the vulnerable. And as Jennifer said, going for eradication, mass vaccination is a strategy of eradication, which I think was amateurish, because you cannot eradicate, as she said, that when you have a reservoir in animal, then you have got so many subclinical cases. Smallpox didn't have subclinical cases. Then the problem of diagnostics also, smallpox could be diagnosed by a layperson also. It can be self-isolated by these assays. There were no subclinical cases. And smallpox vaccine was very effective. So here, everything, we have got a leaky vaccine. All the more reason we cannot go for mass vaccination. It is waste of resources, and you may be giving rise to mutated strains as a different issue. But it doesn't stand to reason when 80% of our people would already be, say, immunity due to natural infection, or they are not vulnerable. And as she said, we cannot catch up with the mutations, because it is like catching a deer in the jungle. You can't run as fast. And she said about cars, so I'm talking about the jungle. It is as difficult as catching a deer in the jungle. But I think you can still catch it if you go only for focused vaccination instead of focused mass vaccination. If you make vaccine only for the vulnerable, you could keep changing it with the new variant, and you can focus it. And mass vaccination doesn't make any sense as on today. So, I mean, I can only talk of the population level at what's happening when you give and all. I'm not a basic scientist, so I wouldn't know much. But that is the difference.
So
Yeah,
Can
go
I
ahead,
just add
Jennifer.
onto your question? So again, it's not about inducing any immune response. You have to induce the proper immune response that's going to provide protection. So that's the issue with these injections is, and I've said this before, is normally we study virus and the pathology of the virus to see how it programs the immune response after recovery from an actively acquired infection. So we haven't really done that. We don't know. More information is coming out as to how the infection programs the immune response. And then we usually use that information to look at what's going to be the best. Not every platform is going to work for every virus. So, traditional platforms like live attenuated vaccines traditionally have the best protective response because they're most like a natural infection. So looking at that and looking at which viral proteins are going to provide the most broad cross-reactive immunity for future responses to future variants. So that's very important. So it's not about inducing any immune response. We have to induce the right immune response in the right amount so we get a robust protection from future variants.
I have
Excellent.
a
Yeah.
question for Jennifer. Actually, I wanted to ask this to number of virologists. Like when you get a recent infection, initially you should have a IgM response, but in COVID you get directly IgG. So can you say something about this?
So my thoughts on that are when there were reports of people having a very early immune response, there were some reports as early as 4 days, 7 days after infection, they were already seeing IgG. That to me is a flag saying that's pre-existing immunity that's being induced. So we have something called original antigenic sin. So when you have a virus that have multiple different variants, and you have pre-existing immunity, when you are infected with a new strain, you actually boost the pre-existing immunity, and that's what we're seeing first. So we're seeing that, and you actually see very little immunity. We see this again, we go back to flu viruses because that's my expertise, and I've seen this in animals. So if they get infected we intentionally infected animals with an H9N2 strain, come back and give them an H5N1 strain, we see a boost in the antibodies to H9N2. So that's called original antigenic sin. So the first virus that they see is the one that you're going to get a boost to immunity to. So when I see this in people, that tells me that that's pre-existing immunity that's being induced and that's coming back to provide some kind of cross protection. It's just not normal to see that so early.
Yeah. So, and this is similar to what you would see with dengue as
Okay.
well. That
Yes.
kind of you respond to the first virus when
Strain.
you've got the second virus. And it would make sense for what we're seeing with regards to triple vaccinated people being at higher risk for Omicron infection if they are responding to the original Wuhan virus with antibodies. Therefore, it means that they're not developing the broad immunity that they would require to produce mucosal immunity. That would probably be a sensible explanation for where we are.
Right. There
So,
was a study done, actually, I believe by Pfizer or Moderna, looking at this. So they had a vaccinated cohort and a cohort that had been unvaccinated and then infected and recovered. And of course, in those who been vaccinated and got infected, they showed that there was little to no anti-nucleocapsid antibodies induced. Whereas in those who were previously infected, because they have a much broader immune response. So this is the thing when you're using one viral protein versus more broad. So there are other viral proteins that interact and are very important for immunity. So it's not just that one and that one is antigenic. So with other proteins, and I've seen this multiple times now with nucleocapsid antibodies being important for more cross-reactive, broader immunity. So they showed in those who were previously infected that they had much more robust anti-nucleocapsid antibody response versus those who had previously been vaccinated and then infected. So there is some evidence that antibodies for that would be key to helping with future or reinfection.
Excellent. So as we come to our wrap up point, I usually like to ask people what they think about where we are and where they think we are going to go. I'll probably start with Carlette on this one. Let me hope we can hear you clearly, Carlette. Carlette, are you hearing
You
me?
know, is major for me, but from here moving forward, I would like to know specifically from Jennifer uh, whether or not you support the assessment of COVID-19 antibodies as reflective of a COVID significant confidence or faith in successive.
Missed the last
But
part of the question,
I'd like to
Carlette.
know what is.
Mhm. Oh, we're still missing it. I think what she was asking,
Do you see the assessment?
we're missing you at the moment, Carlette. Do you think you can get what she said, Jennifer? I think what she was asking was moving forward with regards to I think it was the response, the antibody specific response to the booster. Is that the best almost correlate of protection, which is what we probably seem to be using at the moment?
I don't think so. So, um, again, it's not about inducing any type of immune response. It's what is actually going to be protective. With a lot of virus infections, T cells are key to providing memory and cross protection. So we need to really be looking at T cells. And I think they're actually, usually this is done in like academic labs and it's very expensive. But I think there are some test kits that are coming out now that can look at T cells in more clinical laboratories. So I think, again, we really need to assess this and look at what is the key correlate of protection moving forward to be able to say this. Now, I know that the US is probably the only country not using, not acknowledging actively acquired or natural immunity in those who've been infected and recovered. So that's very interesting given that um, we should be the most innovative and on the forefront of this.
Yeah, excellent. And Amitav, any thoughts as
Uh,
where we're going to be going?
I think again it will be different continents will be experiencing different. I think as far as the Indian continent, India, Pakistan, Bangladesh, it has. I think we have reached the end of the pandemic. But as I said, those continents, particularly Taiwan, New Zealand, Australia, those who have been isolated, I mean, they will be facing. They are facing already more. I don't know. UK is facing long COVID. I'm not very much aware of it, but I think it may be due to the demographics also. Very elderly population, and after some time, if it is so prevalent, the infections, it may be the coincidental finding will be labeled as COVID death. So I mean, there are a lot of hazy things in this pandemic. How you define the cause of death, how you define whether it is COVID is causing or other comorbidities. So I think by and large, it has stabilized. A stable endemic stage has come in the African and the Asian countries, but
Yeah.
Western countries will be facing a different.
Yes, yes, yes. I can completely understand that. So I would just like to say again what a tremendous pleasure it has been to have everyone with us. We've had almost 2 hours of talking. I'm sorry we didn't have some of the other speakers. It would probably have gone on too long, actually, because I think we got just about enough information, and I really appreciate. I'm so sorry Carlette's mic was not as good. Some of the stuff she was saying about the pharmaceutical perspective was tremendous, as always. Jennifer, with regards to her virology, is tremendously appreciated. Professor Banerjee, with regards to the epidemiology and the understanding of the pandemic, I think that he has probably hit the nail on the head. It's over in some parts of the world, but it will continue to be an epidemic. It seems to be in highly vaccinated regions of the world, and therefore the approach to it is going to be much, much different. Thank you, everyone. And again, thank you to all of you for joining us. I really appreciate it. And we'll see you all at the next conference that I'm sure we'll have coming up, talking about COVID-19, everything COVID-19. Thank you to all of you again. Have a great evening.
Thank you, Phil, for having me, and nice to see everyone. Have a good day.
Okay,
Evening.
great.
Thank you, David. Thank you. Thank you, David. Thank you.